Good afternoon, dear students. Today we start our elective course. During this elective course, we will try learn the most important information about outpatient treatment of the most important disease which we can found among cardiology and endocrinology patients. Our first and second lesson will be about arterial hypertension. Today we will talk about arterial hypertension in outpatient care. We will talk about classification, clinical features, diagnostic criteria, and differential diagnosis of different form of arterial hypertension. On the next week we will talk about treatment of arterial hypertension and treatment of hypertensive crisis in outpatient clinic. So we will talk only about ambulance help. We will talk about those help which we can do, which we can give patient in outpatient department. So every word about what we will talk will be before those moments when patients come into hospital. Every information or all information about in hospital treatment you will learn in internal disease course. On this course we will talk about outpatient treatment. My name is Kutsin Alexander. I am a philosophy doctor and associated professor of family medicine and outpatient care department. And after that, beginning information, we will talk about really problem. Really problem is arterial hypertension. Arterial hypertension is common disease. It's the most often found cardiology disease between adult patients. Almost every third adult has arterial hypertension, and especially a number of patients increase with ages. Everything about what we will talk today, tomorrow, and every next classes will be evidence-based medicine. So it's medicine which based on clinical trials, and to understand everything that we will talk about, you must know some information that every recommendation or every treatment which we will use will have class of recommendation and level of evidence. Class of recommendation, as you see here, maybe the next class 1 of recommendation. It means that recommendation is that treatment or procedure is recommended or is indicated, and this evidence or general agreement that a given treatment or procedure is beneficial, useful, and effective. Second class of recommendation means that it's conflicting evidence or a divergence of opinion about the usefulness or efficacy of the given treatment or procedure. Second class divided to two classes. Class 2A, when weight of evidence or opinion of evidence is in favor of usefulness or efficacy. And class 2A, it means that this procedure or this treatment should be considered. Class 2b means that usefulness or efficacy is less well by evidence or opinion, and it means that procedure may be considered. If class 2A means that it should be considered, class 2b means that it may be considered. Third class means that procedure or treatment is not recommended. If we talk about level of evidence, we have three levels of evidence. Level A means that data derived from multiple randomized clinical trials or meta-analysis. It means that it was big clinical trials in which were involved maybe some thousand or even 10,000, 15,000 people, or it may be 2 or 3 less huge randomized trials, or it was made meta-analysis of previous clinical trials, and it was found that this procedure or this treatment is very has a very big basement, which can say about its useful or unuseful. Level of evidence B means that data was derived from a single randomized clinical trial with not high number of participants, maybe before 500 or 1000 or 2000 of people, or large non-randomized studies. And evidence level of C means that it's consensus of opinion of the experts, and results of small studies, for example studies which was made in one clinic or two clinics, but it was not randomized trials, it was not blind trials. So in most cases it's opinion of experts or mind of experts. Definition about arterial hypertension. Arterial hypertension, or more often we will use only single name hypertension, is defined as office systolic blood pressure (SBP) values not less than 140 millimeters, and or diastolic blood pressure values not less than 90 millimeters. Its definition, which is widely used in European Society of Cardiology, but if we talk about American Heart Association, from the 2018 they use some other numbers. If we look for their recommendations, they say that arterial hypertension is office systolic blood pressure not less than 130 and diastolic not less than 80 millimeters. And when we will talk at the next week about treatment of arterial hypertension, we will found some interesting moments that if we begin treatment patient with arterial hypertension, we'll try to decrease blood pressure less than 140 to 90 millimeters. But if this treatment is well tolerated for patient, we try to decrease blood pressure less than 130 to 80 millimeters. So it means that European Society of Cardiology is on its way when I think that in 1 or 2 years they also take into account recommendations that hypertension is more than It's not less than 130 and not less than 80 millimeters. But now in European Society of Cardiology we use 140 to 90. This is based on evidence from multiple randomized clinical trials that treatment of patients with these blood pressure values is beneficial. So it means that a lot of clinical trials and a lot of meta-analysis show the information that blood pressure more than 140 to 80 is not safety for patient. It's dangerous. It can provoke different complication about what we will talk in next some minutes. The same classification is used in younger, middle-aged and older people, whereas blood pressure centiles are used in children and teenagers. Why? Because we have not enough information, because we don't do different clinical trials in this category of patient in this age. On the next slide you can see classification of office blood pressure and definition of hypertension grade. Here you can find that blood pressure may be optimal. Optimal is less than 120 systolic and less than 80 diastolic blood pressure. Normal blood pressure is 120, 128 to 80, 84. Next will be high normal blood pressure, which is high normal in Europe, but it's arterial hypertension in United States. So blood pressure between 130 to 139 and blood pressure from 85 to 89, it's high normal blood pressure in Europe, but it's arterial hypertension in United States. Everything that is more than 140 to 90, it's arterial hypertension, and arterial hypertension divided on 3 grades. Grade 1, or we also call it mild hypertension, it's 140, 159 to 90, 99. Grade 2, or we also call it moderate hypertension, it's 160 to 179 to 100 to 109. And grade 3 hypertension, or we sometimes call severe hypertension, it's not less than 180 to not less than 110 millimeters. Also in this table you may find such things as isolated systolic hypertension. It's such variant of hypertension when we have only high level of systolic blood pressure, it's not less than 140, and normal level of diastolic blood pressure not higher than 90. Also we can find isolated diastolic hypertension. It's more rare variant when systolic blood pressure less than 140 and diastolic high than 90. But isolated systolic hypertension is typical hypertension of elderly age. Why? Because systolic component of blood pressure is depends of stiffness of aorta, and with age impedance or stiffness of aorta decrease, and especially it's typical for people after 55-60 years, and that's why diastolic component of arterial hypertension become less, because this diastolic component depends of impedance of aorta, and when we will found high blood pressure in elderly patient, it in most cases will be only high systolic blood pressure, and rare it will be high diastolic blood pressure. And this difference as more high, as more elderly, as more elderly is patient. It means that systolic is isolated systolic hypertension not often found in 50 years, but very often found in 70, 75 years and more elderly patients, and other specific situations that with age diastolic blood pressure decrease more and more, and pulse pressure, it's a difference between systolic blood pressure and diastolic blood pressure, increase and increase. On the next slide you can find a score. What means score? Since 2003, the European guidelines on cardiovascular disease prevention have recommended use of the systematic coronary risk evaluation. Systematic coronary risk evaluation, short name it's SCORE. SCORE system used because it is based on large representative European cohort data sets, and you can find this score scale by this address when you will go by this address which is present on this slide. And what we can find on this score scale, we see that on this scale we have some measurements, some parameters which we use for calculate cardiovascular risk. For calculate this risk we use such things like sex, woman and man, age from 40 years till 65 years. So we have 40, 45, I don't found it, 50, 55, 60, 65 years. And except that we have a level of total cholesterol, you can find it here, from 4 till 8 millimole per liter. And also we have level of systolic blood pressure from 120 to 180, and smoker and non-smoker. So 5 parameters: sex, age, total cholesterol, systolic blood pressure, and smoker or non-smoker. When we use this combination, we can calculate risk of patient. It's very quantitative test, because when you will consulting patient, when you will try to learn him about modifying lifestyle, you must use some instruments for give patient information which can help you to change something in attempt of patient to his life. So it's one of instrument which you can use. How you can use this instrument in your clinical practice? For example, we can try imagine clinical situation when you have man 50 years of old with which is smoker, which has a level of cholesterol, of total cholesterol 7. So smoker is here, 50 years is here. So we have this square. In this square we will look total cholesterol level 7 and level of systolic blood pressure 180. So risk of this patient will be 12%. What means risk? The score system estimates a 10-year risk of first fatal atherosclerotic event in relation to age, sex, smoking habits, total cholesterol, and systolic blood pressure. The score system only estimates the risk of fatal cardiovascular events. So it means that in next 10 years, this patient has 12% risk of fatal cardiovascular event. It means fatal myocardial infarction, stroke, or maybe aortic dissection, or maybe death because of decompensated chronic kidney disease. So 12% has this patient during next 10 years. So if you ask patient stop smoking, then we go in this square, decrease level cholesterol till 4 millimole per liter, and level of systolic blood pressure till 140 millimeters. So risk of this patient change from 12% to 2%. So it's very important instrument which can give information for patients that something he must change in his life for prolong this life and to prevent different bad prognosis, different bad situation. Other things that you can use in this table, in this scale, it's calculate of age of vessel. What it means? It means that when you found a patient with such parameters that we have told some minutes ago. So you found a man which has total cardiovascular risk 12%. You can compare him with those men with the same parameters which also are smoker but has the least blood pressure, so 120 millimeters, is the more elderly and has a less level of cholesterol. So you can compare that patient who are smoker has level of cholesterol 7 and systolic blood pressure 180 millimeters, has the same risk as 65-year of old man which also is smoker but has level of cholesterol 6 and blood pressure 120. It also give information for patient that his risk is the same that risk of 65-year-old patient with normal blood pressure. It's also one of instruments which can give imaging for patient and realistic situation in what bad condition is your patient now. When we talk about score scale, we must remember that cardiovascular risk assessment with the score system is recommended for hypertensive patients who are not already at high or very high risk due to established coronary vascular disease, due to renal disease or diabetes. What means high and very high risk? When we return and look to a score scale, we can find different cells in this scale. Some of them is green, some of them are green, other yellow, other orange, and the last is red and even brown. These cells means different risk of development of coronary vascular disease during next 10 years. When we talk about green cells, it means that this risk is like general population risk. When we saw yellow cells is are cells with low risk. Here, low risk is risk in people in which calculated 10-year score is less than 1%. Moderate risk when score risk is between 1 to 5%. It's mostly patients with second grade of hypertension, and a lot of people are middle-aged people. Patient with high risk and very high risk. This patient is patient in which present some complication or some not complication, in which present changes from target organs or present diabetes mellitus. So for such patients includes patients in which marked elevation of risk factors, particularly level of cholesterol very high, more than 8 millimole per liter, or familiar hypercholesterolemia in patients with homozygote familiar hypercholesterolemia. Level of cholesterol total cholesterol may increase even till 13, 14 and 18 millimole per liter, or patient with third grade of hypertension. Besides that, it also patient with diabetes mellitus, except some young people with first type of diabetes mellitus without major risk factor. For patients with high risk, also involve patient with left ventricular hypertrophy, which is answer of left ventricle to increase of blood pressure. It's also patient with moderate chronic kidney disease with estimate glomerular filtration rate between 30 and 59 milliliter. It means that it's patient with third stages of chronic kidney disease. And the patient with very high risk, it's patient with documented coronary vascular disease. What it means? It's patient with previous acute myocardial infarction, previous acute coronary syndrome. It means ST elevation, STEMI, non-STEMI. Patient with coronary or other artery revascularization. Patient with problem in carotid basin, for example, patient with stroke or transient ischemic attack, patient with aortic aneurysm, or patient with peripheral artery disease, with disease of lower extremities. Patient in which was documented or imaging significant plaque, more than, not less than 50% stenosis on angiography or ultrasound, or not less than 50% stenosis in carotid intima media in a carotid system. Patient with diabetes mellitus with target organ damage, for example proteinuria, or with a major risk factor such as third grade of hypertension or hypercholesterolemia. A patient with severe chronic kidney disease with estimated glomerular filtration rate less than 30 milliliter, it means that fourth and fifth stages of chronic kidney disease. Such patient has calculated 10-year score risk more than 10%. Factors which can what about factors which can influencing cardiovascular risk? It's such factor like sex in men more oftenly will be found in men more men has have more risk for development of different complication of arterial hypertension and more early development arterial hypertension than women. Near 24% adult men and near 20% of adult women have arterial hypertension. Age, as more elderly people as more high risk of development of arterial hypertension. For example, prevalence more than 60% in people aged more than 60 years, 60% people aged more than 60 years. In such category, we may reveal arterial hypertension. Smoking, current or past history, total cholesterol and total cholesterol and level of high density lipoprotein cholesterol, uric acid level, presence of diabetes, overweight or obesity, family history of premature cardiovascular disease. For men, it's history of cardiovascular disease like myocardial infarction, previous myocardial infarction in proband or in sisters or brothers, myocardial infarction, stroke, or sudden cardiac death. In men aged less than 55 years, in women aged less than 65 years. Family or parents' history of early onset hypertension, factor which involve cardiovascular risk. It's only early onset menopause. Lifestyle, bad lifestyle, psychological and socio-economic factors. Heart rate in rest more than 80 beats per minute. Some words about some of these factors which increase cardiovascular risk. There's also emerging evidence that an increase in serum uric acid, it's one of the factors about what we had talked, then in serum uric acid to levels lower, so high level of uric acid, but lower than those typically associated with gout. Such increasing level of uric acid associated with is independently associated with increased cardiovascular risk in both population, in general population and in hypertensive patients. So measurements of serum uric acid is recommended as part of the screening of hypertensive patients. Systolic blood pressure, it's very important things. So systolic blood pressure more than 140 millimeters accounts for most the mortality and disability burden. So systolic blood pressure is more important than diastolic blood pressure. It's accounts for 70% of mortality of cardiovascular disease, and the largest number of systolic blood pressure related deaths per year are due to ischemic heart disease. Near 5 million people deaths after stroke, ischemic stroke, or ischemic heart disease development due to arterial hypertension. Hemorrhagic stroke near 2 million people, and ischemic stroke near 1.5 million people. Both office blood pressure and out of office blood pressure have an independent and continuous relationship with the incidence of several cardiovascular events. Hemorrhagic stroke, for example, ischemic stroke, myocardial infarction, sudden cardiac death, heart failure, and peripheral artery disease connected with as office blood pressure and as out of office blood pressure. Increased pulse, we talk about it, about heart rate more than 80 beats per minute. So increased pulse Increased pulse pressure, it means difference between systolic and diastolic blood pressure. So increased pulse pressure has additional adverse prognostic significance. Next slide, it's slide about asymptomatic HMOD. What means HMOD? HMOD means hypertension-mediated organ damage, HMOD. Hypertension-mediated organ damage. Other words that we can use, it's damage of target organs. For target organs in patients with arterial hypertension, we involve 5 organs. First of all, it's heart. Next organ is vessel or a vessel. Vessels. Third organ is retina. Fourth organ is kidney, and the last organ is brain. You may call it in order that you prefer. It doesn't matter, but these 5 organs we marked as target organs, and HMOD, it's hypertension-mediated organ damage. HMOD describe hypertension-induced structural or functional changes in major organs. There are 3 important considerations. First important consideration: not all features of HMOD are included in the score system, and I can say that the most of this hypertension-mediated organ damage founding are not included in score system. And several hypertensive mediated organ damage, for example, cardiac changes, vascular changes, and retinal changes, have well established adverse prognostic significant effect of the development of complication of arterial hypertension, and it's not involved in score system. Next things, that the presence of HMOD is common and often goes undetected, because when we have second stage of arterial hypertension, we very often have asymptomatic HMOD. So oftenly it's not detected. And the presence of multiple hypertensive mediated organ damages in the same patient is also common and further increase cardiovascular risk. Consequently, the inclusion of hypertensive-mediated organ damage assessments is important in patients with hypertension and helps identify high-risk patients and very high-risk patients who may otherwise be misclassified. What things involved in asymptomatic HMOD? It's arterial stiffening, pulse pressure, so it means difference between systolic and diastolic blood pressure. It's especially important in older people, and especially important when this level is more than 60 millimeter, not less than 60 millimeter. Carotid femoral pulse wave velocity more than 10 meter per second. We will talk some words in next slides. ECG criteria of left ventricular hypertrophy, also we will talk. Echocardiographic left ventricular hypertrophy. Microalbuminuria, it's a level of albumin in between 30 to 300 milligram per day, or elevated albumin creatinine ratio between 30 to 300 milligram per gram, or 3.4 34 milligram per millimole. Moderate chronic kidney disease, it's it's a third stage of chronic kidney disease, or severe chronic kidney disease, it's fourth and fifth stages, when estimated glomerular filtration rate is less than 30, uncle brachial index less than 0.9, and advanced retinopathy, hemorrhages or exudates, and papilloedema. Established cardiovascular or renal disease, we talk about it when a patient has third stage of arterial hypertension. What established cardiovascular disease? It's cerebrovascular disease like ischemic stroke, cerebral hemorrhage, or transient ischemic attack. Coronary artery disease, it's myocardial infarction, angina pectoris, or myocardial revascularization. Presence of atheromatosus plaque on imaging, it means more often when we talk about imaging of carotid artery, and heart failure, including heart failure with preserved ejection fraction, peripheral artery disease, and atrial fibrillation. Here you can see that cardiovascular risk estimate by score system may be modified in in first generation immigrants to Europe, and cardiovascular risk scores in such patients may be adjusted by correction factors. So, for example, for first generation immigrants from Southern Asia, from Southern Asia, we must multiple results which we divided by score to 1.4. For immigrants from, for example, Northern Africa, we must multiple to 0.9. On this figure, you can find the impact of progression of the stages of hypertension associated disease from uncomplicated, which we see here, from uncomplicated through asymptomatic to established disease, according to different grades of hypertension and the presence of cardiovascular risk factors, hypertension-mediated organ damage, or comorbidities, and it's illustrated in figure 1 for middle-aged individuals. So for middle-aged individuals, we can calculate the factors. So middle-aged, it means mostly those patients who are not involved in score system, for example, between 30 to 45 years. We can calculate that if they has grade 2 of arterial hypertension plus 3 factors and more factors of risk, they have high risk. What rules of blood pressure measurement? Patients should be seated comfortably in a quiet environment for 5 minutes before beginning blood pressure measurements. It means that blood pressure must be measured not at the beginning of patient visit, but mostly in the middle or even in the end of patient visit, because there are a lot of factors which have an effect to level of blood pressure. For example, if patient is a smoker and he was smoking some minutes before coming, smoked some minutes before come into the visit, blood pressure after every cigarette can increase till 20 degrees, till 20 millimeters systolic blood pressure, and till 10 millimeter diastolic blood pressure. And often it's need near 30 minutes to return blood pressure to really level. That's why very often it's important to measure blood pressure at the end of patient visit. Should be recorded 3 blood pressure measurement, 1-2 minutes apart, and additional measurement only if the first 2 readings differ by more than 10 millimeters. Blood pressure is recorded as the average of the last 2 blood pressure readings. So we found middle things between last 2 blood pressure measurements. Additional measurements may have to be performed in patients with unstable blood pressure values due to arrhythmias, such as in patients with atrial fibrillation. Very important measurement blood pressure for patients who had serious arrhythmia like atrial fibrillation or atrial flutter. For such patients, very important measurement blood pressure with mechanic manometer, but not with automated devices, because automated devices will give not valid measurement for blood pressure. Use a standard bladder cuff. It must be near 12-13 centimeter wide and 35 centimeter long for most patients, but you must be ready that sometimes you will have obesity patient, or patient with huge obesity, with third stage of obesity, and for such patient such bladder cuff will be not enough. So you must have also smaller cuffs and larger cuff for a arm circumference more than 32 centimeters. The cuff should be positioned at the level of the heart, with the back and arms supported to avoid muscle contraction and isometric exercise dependent increase in blood pressure. So it means that arm must be stay on the table and not must be in the air or near the leg. So it must be on a horizontal surface, and cuff should be positioned in the lower 1/3 of shoulder at the level of the heart. When using auscultatory methods, use cortical sounds, reduction and disappearance. First reduction and disappearance. Cortical sounds, it's first and 5 phase of cortical sounds to identify systolic blood pressure and diastolic blood pressure respectively. Measure blood pressure in both arms at the first visit to detect possible between arm differences. Use the arm with the higher value as the reference. You must remember, and you must say patients that after first measurement on first visit, you must find those arms where blood pressure is more high, and ask patient to measurement blood pressure only on this hand, because this hand you will be taking into account are your treatment is success or not success. A consistent and significant systolic blood pressure differences between arms, it means more than 15 millimeters, is associated with an increased cardiovascular risk, most likely due to atheromatosus vascular disease. So such patient must be revision for presence or absence atherosclerotic plaque in arteria subclavia or arteria brachialis, for example. Orthostatic hypotension is defined as reduction of systolic blood pressure of more than 20 millimeters or diastolic blood pressure more than 10 millimeters within 3 minutes of standing, and such orthostatic hypotension is associated with an increased risk of mortality and cardiovascular events. It's more oftenly typically for elderly patients, and some drug, for example, AC inhibitor, can provoke orthostatic hypotension. You must remember about it. Heart rate should also be recorded at the time of blood pressure measurements, because resting heart rate is an independent predictor of cardiovascular morbid or fatal events. Also, heart rate is not included in any cardiovascular risk algorithm. So heart rate not included in cardiovascular risk algorithm, but it's important predictor of fatal events. Measure blood pressure 1 minute and 3 minutes after standing from a seated position in all patients at the first measurement to exclude orthostatic hypotension. I had talked what it means, orthostatic hypotension. Record heart rate and use pulse palpation to exclude arrhythmia. It's very important to exclude especially atrial fibrillation, which may be as complicated of arterial hypertension, but it also may be as concomitant disease and may worsening prognosis of patients. And besides that, atrial fibrillation need a specific treatment to prevent strokes and other cardioembolic complication. General recommendation about blood pressure measurement is the next. Screen programs for hypertension are recommended. It's class of recommendation 1 and level of evidence beam. Screening programs recommended. All adults 11 years or older should have their office blood pressure measured and recorded in their medical file. Further, so it means after first measurement, further blood pressure recording is indicated at least every 5 years. If blood pressure is optimal, it means be less than 120 to 80. If blood pressure remains normal, 120, 128, 129 till 80, 85, it must be recording every 3 years. And if blood pressure remains high normal, 130, 138, 85, 89, blood pressure must be measured annually. In older patients, older after 50 years, I don't understand, it's not older, but in patient after 50 years, more frequent screening of office blood pressure should be considered, because this is such age after what often can be found arterial hypertension for each blood pressure category, because of the increase of systolic blood pressure with aging, because of isolated systolic arterial hypertension. It is recommended that office blood pressure should be measured in both arms at least at the first visit, because to find difference between two hands. We talk about it. two extremities. If between arm difference is recorded, then it's recommended that all subsequent blood pressure readings use the arm with the higher blood pressure reading. Class of recommendation 1, level of evidence C. Next, if between arm difference in blood pressure is recorded, then it's recommended that all subsequent use the arm. We talk about it. It is recommended that the diagnosis of hypertension should be based on repeated office blood pressure measurement on more than one visit, except when hypertension is severe. So if we measurement not less than 180 to 110, we can say about arterial hypertension. So with grade 3. In other situation, we must repeat as minimum repeat measurement of blood pressure, and as minimum 2 measurements must be present at each visit. 3 blood pressure measurement should be recorded at each visit, 1-2 minutes apart, and additional measurement if first 2 measurements differ more than 10 millimeters. We talk about it. Out of office blood pressure measurement with ambulatory blood pressure measurement or home blood pressure measurement, provided that these measurements are logistically and economically feasible. We'll talk about it. Screening and diagnosis of blood pressure of arterial hypertension will be the next. Optimal blood pressure, repeat every 5 years. Normal blood pressure, repeat every 3 years. High normal, repeat every year, annually. Consider masked hypertension. We'll talk about masked hypertension. It means that hypertension present only in out of ambulance measurement. Out of office blood pressure, in this situation we use out of office blood pressure measurements. It means ambulatory blood pressure measurement or home blood pressure measurement. Hypertension, arterial hypertension diagnosis if not less than 140 to 80. Use either to confirm diagnosis. Repeated visits for office blood pressure measurement. Out of office blood pressure measurement, it may be or ambulatory or home blood pressure measurement. And about indication to these measurements we will talk on in the next slide. Here in this table you can find clinical indications for home blood pressure monitoring or ambulatory blood pressure monitoring. When we prescribe such measurements, such monitoring, conditions in which white coat hypertension is more common. It means that when patient has blood pressure only in when he comes to doctor, and we call it white coat hypertension. It's first grade of hypertension on office, and marked office blood pressure elevation without hypertension mediated organ damage. Conditions in which masked hypertension is more common. Masked hypertension is other variants that white coat, if white coat presence only on visit and absence at home. In this situation, hypertension present at home, at work, and absent on visit. We think about masked hypertension when patient has high normal office blood pressure, 130, 138 to 50, 85, 89. Normal office blood pressure in individuals with hypertension mediated organ damage or at high total cardiovascular risk. Postural and postprandial hypertension in untreated and treated patients if after stand up or after meal appear hypotension, we must check for presence of arterial hypertension, and we prescribe blood pressure monitoring. Evaluation of resistance hypertension, we will talk about it, a special slide. Evaluation of blood pressure control, especially in treated higher risk patients. If patient has high risk and we prescribe treatment, it's good to control result. Aggregated blood pressure response to exercise. So it means or very high increase of blood pressure on physical exertion, or decrease of blood pressure, hypotension on physical exertion, which is not typical for normal situation. In normal situation, blood pressure increase during physical exertion, but it must increase slowly or very slowly or step by step, and don't must decrease. When there is considerable variability in the office blood pressure, evaluating symptoms consistent with hypotension during treatment. If patient has some symptoms which can be conducted with hypotension, for example dizziness, for example weakness, we must control and we prescribe patient antihypertensive drugs. We must control blood pressure. Maybe in some moments of day patient has hypotension variant, and because of that he has his symptom. Specific indication for ABPM rather than HBPM is assessment of nocturnal blood pressure values and dipping status. Suspicion of nocturnal hypertension, it means that blood pressure preferably increase in the evening and during night, and such condition as sleep apnea, chronic kidney disease, diabetes, endocrine hypertension, or autonomic dysfunction. Comparison of ABPM and HBPM. What about advantages? ABPM can identify white coat and mask the hypertension, and HBPM can do the same. ABPM stronger prognostic evidence. It's night-time readings when patient is sleeping. Measurement when patient sleep. Measurement in real-life settings. Additional prognostic blood pressure phenotypes, and abundant information from a single measurement session, including short-term blood pressure variability. What about home measurement? It also can identify white coat and mask hypertension. It's cheap and widely available. It doesn't need to pay any costs, pay any money for this measurement, because patient only must know how correctly measurement blood pressure, and it may be due in any moment. For ABPM, patient must be recorded first of all. In the different clinic, patient will use this equipment during one day, and it's costly. Measurement in home setting, which may be more relaxed than at the doctor's office. It's the most important for white coat. Patient engagement in blood pressure measurement, easily repeated and used over longer periods, even to control what is how success is treatment with different antihypertensive drugs. What disadvantages? ABPM is expensive, sometimes limited availability, and can be uncomfortable because every 15 minutes cuff will be pumped with air to measurement blood pressure, and it will be make it will it will it it the duration of this during one day, during whole day, and even in the evening. Disadvantages of HBPM: it's only static blood pressure is available, so blood pressure not in physical exertion. Potential for measurement error, especially if patient use automatically equipment for different arrhythmias like atrial fibrillation or a frequent extrasystoles, and no nocturnal readings. Next, risk factor, especially risk factor of hypertension. It's family and personal history of hypertension, cardiovascular disease, stroke or renal disease. Family and personal history of associated risk factor, smoking history. For what reason I talk about it? You must ask about these things, especially in first contact with patient which has arterial hypertension. You must ask about smoking history, you must ask about dietary history and salt intake, because sometimes we have salt potentiate variant of arterial hypertension. Alcohol consumption, overdoses of alcohol also can provoke arterial hypertension and even hypertensive crisis. Lack of physical exercise or sedentary lifestyle. History of erectile dysfunction. Erectile dysfunction is important, especially after 50-60 years, and it's important sometimes as when you must decide make decision what drugs will be preferable, because some drugs, for example alpha adrenal blockers, has a positive effect not only on blood pressure, even on prostata function, and for example, on other hand, if we talk about beta blockers, especially in high doses, selective beta blockers, or middle or even small doses of non-selective beta blockers, can provoke erectile dysfunction. Sleep history, snoring or sleep apnea. It's information important because often sleep apnea is one of the high or important reason of resistance hypertension. Previous hypertension in pregnancy or preeclampsia. It's very important when you talk about anamnesis in women, especially if you found high blood pressure in young women before menopause. So you must ask about preeclampsia or eclampsia in such category of patient. History and symptoms of hypertensive mediated organ damage or cardiovascular disease, stroke and renal disease also must be asked during physical examination. About brain and eyes, you must ask about headache, vertigo, syncope, previous syncope, impaired vision, transient ischemic attack, sensory or motor deficit. Look for this function. Previous stroke, carotid revascularization, cognitive impairment, and dementia. Especially it's important in elderly people, and very often cognitive impairment and dementia is a result of long history of arterial hypertension. About heart, chest pain, shortness of breath, edema, previous myocardial infarction, coronary revascularization, syncope situation, history of palpitations or arrhythmias, especially it's important for atrial fibrillation, or symptoms of heart failure. For these symptoms, we involve shortness of breath and edema. Kidney. Symptoms from kidney damages may be thirst, polyuria, nocturia, hematuria, urinary tract infections. Peripheral arteries involving in process may be signs of this may be cold extremities, intermittent claudication, pain-free walking distance, especially if you ask patient how much distance you can walk without pain, and if patient has peripheral vessel disease, especially with the lower extremities problem, you will hear that it's need sometimes 100 or 200 meters for a peer of pain when patient walking some distance. And it was very important or maybe pathognomic symptoms when you must see about peripheral artery disease. Pain at rest, peripheral revascularization. It means revascularization, for example, in lower extremities in patient for intermittent claudication. Also, signs of peripheral vessel disease may be erectile dysfunction. Patient of family history of chronic kidney disease, for example, polycystic kidney disease, it's more important when we think about secondary hypertension. History of possible secondary hypertension. When we must when we must think about secondary hypertension, it's young onset of second or third grade of hypertension when patient is less than 40 years. So in such young patient, we every time think about secondary hypertension. When patient has sudden development of hypertension or rapidly worsening blood pressure in older patient. So in situation when a long time a patient was compensated with blood pressure and everything everything was normal and rapidly worsening, you must also think about secondary hypertension. History of renal or urinary tract disease also may be one of key about what you must think about secondary hypertension. Recreational drug or substance abuse, concurrent therapies. What drugs involve in process which can provoke development of secondary hypertension? It's corticosteroids, which oftenly used by patients with different rheumatology disease, or patient with severe bronchial asthma, severe COPD. Nasal vasoconstrictor, oftenly patient overdoses with nasal vasoconstrictors when they have rhinitis, because often rhinitis has allergic reason and patients don't know about it, and by nasal vasoconstrictor it doesn't help, but it's worsening situation with rhinitis and may provoke development of secondary hypertension. Chemotherapy can provoke yohimbine or licorice can provoke secondary hypertension. Repetitive episodes of sweating, headache, anxiety, or palpitation suggestive of pheochromocytoma. History of spontaneous or diuretic-provoked hypokalemia, episodes of muscle weakness and tetany. In this situation, we must think about hyperaldosteronism. When we have muscle weakness and tetany, hyperaldosteronism. Symptoms suggestive of thyroid disease or hyperparathyroidism. History of current pregnancy or current pregnancy and oral contraceptive use. Near 10-20% of women who use contraceptive has increased risk of development of blood pressure. History of sleep apnea, especially if we talk about resistant arterial hypertension. Case steps in physical examination. Case steps in physical examination. Body habitus. We must measurement weight and height of patient on a calibrated scale with calculation of body mass index. And except that, weight will be need for calculate of estimated glomerular filtration rate. Waist circumference, it's important to say about presence of metabolic syndrome, about what you will have and separate topic at the end of the semester. Signs of hypertensive mediated organ damages. Its neurological examination must be done and check cognitive status. Fundoscopic examination for hypertensive retinopathy. Very important things which can be done on any ambulance. Palpation and auscultation of heart and carotid arteries. Sometimes we can hear some noises which can say about different valvular problems. Especially it's typical for elderly age because of calcification of aorta. Palpation of peripheral arteries for understand what is pulse of patient, and it's regular, irregular, and are there present any differences between two hands, because if we suspect atherosclerotic problem with peripheral artery, we will find not only different blood pressure on both hands with difference more than 15 millimeters, we also can palpation the difference pulse, different different elements of pulse, the different power of pulse on different hands, and also can suspect atherosclerotic plaque in one or other hand vessel. Comparison of blood pressure in both arms. Secondary hypertension. For secondary hypertension, important is skin inspection, cave outlet patches of neurofibromatosis. It's element of pheochromocytoma. Kidney palpation for signs of renal enlargement in polycystic kidney disease, and important also it's auscultation of renal arteries, because when patient has renal artery stenosis or fibromuscular dysplasia, sometimes we can hear noise under renal artery. So on first time measurement or first time visit of patient, we must do it. Auscultation of heart and renal arteries for murmurs, murmurs, or bruits indicative of aortic coarctation or renovascular hypertension. Aortic coarctation we suspect in young patients. Comparison of radial with femoral pulse to detect radiofemoral delay in aortic coarctation. And for aortic coarctation, it's typical not only difference between pulse, typical also difference between blood pressure, because if we suspect blood pressure, if we measurements that young patient has high blood pressure and we suspect that it's secondary hypertension, we must measurement blood pressure not only on hand, we also must do it on lower extremities, on hip, for example. And in normal situation, blood pressure on lower extremities will be more high or higher than on upper extremities. In situation of aortic coarctation, because of stenosis in ascendens aorta or arcus of aorta in this place, and because of stenosis, pulse on lower extremities and blood pressure on lower extremities will be less than on upper extremities. Signs of Cushing disease or acromegaly, and signs of thyroid disease. Routine workup for evaluation of hypertensive patients. What laboratory test we will prescribe for first time identified arterial hypertension, for primarily found arterial hypertension? We will measurement hemoglobin level and or hematocrit level. For found maybe some anemia or polycythemia. Polycythemia may be really primary polycythemia or Vaquez disease, can be one of factor of high blood viscosity and one factor of arterial hypertension. Fasting blood glucose and glycated hemoglobin for exclude presence of diabetes mellitus. Blood lipids or lipid profile, we must measurement not only total cholesterol, to understand are there any indication for statin prescription. We must know LDL cholesterol, low density lipoprotein cholesterol, and important which is level of high density lipoprotein cholesterol. Except that if we prescribe statins, we must recheck level of LDL in some period. You will have one lecture about dyslipidemia, so I will not stop on this question. Blood triglycerides, it's important things, it's component of lipid profile. Also, you will talk about it on this lipidemia topic. Blood potassium and sodium. It may change in patient with problem with a problem for example, hyperaldosteronism or hypocorticism. Blood uric acid, we had talked that it's important things which can worsen prognosis, especially if level is more high that upper level, but not very high, which is typical for gout. Blood creatinine and estimate glomerular filtration rate, very important things which say about kidney function and involving of kidney into process in patient with arterial hypertension. Blood liver function tests, AST, ALT level, it's important for patient, especially if we want to prescribe or had prescribed statins. Urine analysis, microscopic examination, urinary protein by dipstick test, or ideally albumin creatinine ratio, and 12-lead ECG. Basic screening test 12-lead ECG. It's a screen for left ventricular hypertrophy and other possible cardiac abnormalities, and to document heart rate, it's regular, irregular, and what is number of heart rate, what is level of heart rate, and cardiac rhythm. It's regular, irregular, atrial fibrillation, and etc. Urine albumin creatinine ratio we do to detect elevations in albumin excretion, indicative of possible renal disease. It's component which will be changed in patient with chronic kidney disease. Blood creatinine and estimated glomerular filtration rate. We need to detect renal disease, we need to detect chronic kidney disease and stage of chronic kidney disease, because of different stage need different algorithm of treatment. Fundoscopy to detect hypertensive retinopathy, especially in patients with second or third grade of hypertension. More detailed screening for patients in whom we suspect hypertensive mediated organ damage. It's echocardiography. Oftenly it cannot be done on family ambulance, so often it will be need to do it in specialization center. Echocardiography giving information about cardiac structure, cardiac function. When this information will influence treatment decision, oftenly when we prescribe drugs, we will repeat echocardiography in 1 or 2 years to understand are other prescription is effective, have we reversible changes of left ventricular hypertrophy, because it's important result of our treatment. Carotid ultrasound, it's also detailed screening which cannot be done at family ambulance. We do it to determine the presence of carotid plaque or stenosis, particularly in patients with vascular disease or peripheral vascular disease, or especially for patients with different, for example, transient ischemic attack or previous stroke. Abdominal ultrasound and Doppler studies. In which situation? To evaluate renal size and structure when we suspect secondary renoparenchymatosal hypertension or renovascular hypertension. Evaluate abdominal aorta for evidence of aneurysmal dilatation and vascular disease. Examine adrenal glands for evidence of adenoma or pheochromocytoma. The most perfect for this situation is CT or MRI, preferred for detailed examination. Renal artery Doppler studies when we suspect renal artery stenosis or fibromuscular dysplasia. So in this situation, when we suspect renovascular disease as a reason of secondary hypertension, we will do renal Doppler. Next, it's PWV, pulse wave velocity, an index of aortic stiffness and underlying atherosclerosis. ABI, it's ankle brachial index. It's screened for evidence of leads. It's lower extremity artery disease or peripheral artery disease. For patients with claudicatia intermittent. Cognitive function testing to evaluate cognition in patients with symptoms suggestive of cognitive impairment. Brain imaging to evaluate the presence of ischemic or hemorrhagic brain injury, especially in patients with history of previous cardiovascular disease in cerebrovascular disease. So, criteria, the most commonly simple criteria and recognized cutoff points of electrocardiograms that confirm presence of left ventricular hypertrophy. It's Sokolov line criteria. When we make a sum of S wave in V1 lead and R wave in V5 lead. If this sum is more than 35 millimeter, we say that it's criteria of left ventricular hypertrophy. We plus S in V1 or V2, we take those lead where deep of S wave is more, and plus R in lead V5 or V6, we use those lead where height of R wave is more, and if this sum more than 35 millimeter, it's say about left ventricular hypertrophy. If we have R wave in AVL more than, not less than 11 millimeter, it's also criteria of left ventricular hypertrophy. And coronal criteria, it's S wave in V3 plus R wave in AVL lead. If this sum is more than 28 millimeter in men and more than 20 millimeter in women, we suspect left ventricular hypertrophy. The ECG can confirm left ventricular hypertrophy, but it has bad possibility for exclude left ventricular hypertrophy. We call that it has low sensitivity criteria. It cannot exclude Left ventricular hypertrophy, when detailed information on cardiac structure and function will influence treatment decision, it's recommended to do echo-CG. On echo-CG, the most easy criteria that confirm presence of left ventricular hypertrophy, it's two criteria. It's criteria of left ventricular mass to height, gram to square meter, which must be more than 50 in men or more than 47 in women to confirm presence of left ventricular hypertrophy. And other criteria, it's left ventricular mass to BSA. BSA is body surface area. Also in gram to square meter, must be more than 115 in men and more than 95 in women to confirm presence of left ventricular hypertrophy. Also important things which is which often says that heart has an answer to left to increase blood pressure. It's dilation of left atrial size. If normal left atrial size is less than 40 millimeters from anterior to posterior wall in patient with in patient with left atrial dilation, this size is more than 40 millimeters. Here you can find other criteria which must be calculated by echo cardiologist. Criteria of size of left atrium you will find automatically as a result of echo-CG. Next, it's carotid changes in carotid artery in hypertension. The most important things with change in carotid arteries is intima media thickness, IMT, or presence of plaques in carotid arteries. IMT, intima media thickness, and the carotid bifurcation say about primarily atherosclerosis, intima media thickness, the level of the common carotid artery, say about primarily hypertension related hypertrophy. IMT more than 0.9 millimeter is considered abnormal and say about answer of carotid artery for arterial hypertension. But also the presence of plaque can be identified by an intima media thickness more than 1.5 millimeter or make a stenosis more than 50% of the surrounding carotid, say about presence of carotid plaques, which is significantly, which is clinical significant. However, routine carotid imaging is not recommended because it's costly and it's not need for every patient. Pulse wave velocity also is not recommended for routine practice, but carotid femoral pulse wave velocity is the gold standard for measuring large artery stiffness. This measurements say about pathophysiological determinant of isolated systolic hypertension and age-dependent increase in pulse pressure. So difference between systolic blood pressure and diastolic blood pressure development because of changes of stiffness of large artery. But it's not recommended for routine practice. Ankle brachial indexes. Ankle brachial index also not recommended for routine practice. No, it's not this method that routinely use. But low uncle brachial index indicates less than 0.9, indicates lower extremity artery disease or peripheral artery disease, and low ABI being associated with an almost twofold greater than yes cardiovascular mortality and major coronary event rate. Kidney in hypertension. Kidney in hypertension. Hypertension is the second most important cause of chronic kidney disease after diabetes. So diabetes is the primary reason of chronic kidney disease. Next will be hypertension. So it's not logically, but the main reason of chronic kidney disease, it's not primarily kidney disease. It's disease of other organs which damage kidney. So the diagnosis of hypertension which damage kidney is based on the reduced renal function and detection of albuminuria. Chronic kidney disease is classified according to result of estimated glomerular filtration rate, which the best formula for calculated is CKD epidemiology collaboration formula. A link for this formula you can find here. There is link for formula. The albumin creatinine ratio is measured from a spot urine sample, mostly from the morning urine, and is a preferred method to quantify urinary albumin excretion serum creatinine. EGFR and albumin creatinine ratio should be documented in all hypertensive patients, and if CKD is diagnosed, if chronic kidney disease is diagnosed, this analysis must be repeated at least annually, especially if prescribed drugs which can increase level of creatinine and decrease level of estimated GFR, and as a result increase stages of chronic kidney disease. Hypertensive retinopathy, we can found retinopathy by fundoscopy. Fundoscopy should be performed especially in patients with grade 2 or 3 hypertension or patient with diabetes mellitus. Visualize the fundus through smartphone technologies should increase the feasibility or more routine fundoscopy. But also at every family ambulance must be present ophthalmoscope. So if ophthalmoscope is present, this procedure is not hard and it's not expensive for every family doctor. By fundoscopy, you may find presence of retinal hemorrhages, microaneurysms, heart exudates, cotton wool spots, and papilloedema. This changes is highly predictive highly predictive of cardiovascular mortality. In contrast of them, evidence of arterial narrowing, either focal or general and arteriovenous nicking, have less predictive value. Brain changes in hypertension. Hypertension increases the prevalence of brain damage, especially presence of transient ischemic attack and stroke are the most dramatic clinical manifestations. In the asymptomatic phase, brain damage can be detected by MRI as white matter hyperintensities, silent microinfarcts, but it should be sought in all hypertensive patients with neurological disturbances, cognitive decline, and particularly memory loss. On this table you can find sensitivity to detect treatment-induced changes, reproducibility and operator independence time to changes, and prognostic value of changes provided by markers of hypertension-mediated organ damage. It's this table only for only as picture, in which you can find that some method has low sensitivity. For example, determinant of left ventricular hypertrophy by ECG has low sensitivity but high reproducibility and operator independence, and has time to changes on ECG is moderate time, more than 6 months. Often it's 1 or 2 years need to find new changes on ECG during treatment, and prognostic value of changes. Left ventricular hypertrophy by ECG has prognostic value of changes, so it may change. And you may find these changes on ECG, but not for every method these things may be found. So it's not for learning this table, it's only for understanding that not every method is very important, but some method is very important and not expensive, so may be used at ambulance in ambulance practice. Clinical evaluation and hypertension mediated organ damages assessment. You also not need to learn these things. It's only a table where you can find a class of recommendation and level of evidence for different method of diagnostic of hypertensive mediated organ damages. Hypertension is defined as resistant if after treatment with recommended treatment strategy fails, and blood pressure not decrease less than 140 and less than 90 millimeters respectively, and the inadequate control of blood pressure is confirmed by ambulance blood pressure measurement or home blood pressure measurement in patients whose adherence to therapy has been confirmed. Treatment with optimal or best tolerated dose, it means that it involves 3 or more drugs, but especially between these drugs should be diuretic, and typically other drugs will be or calcium channel blocker or AC inhibitor or ARB will be the second component, and third component will be diuretic. Oftenly pseudo-resistance hypertension and secondary causes of hypertension should be excluded to confirm really resistance hypertension. Pseudo-resistance hypertension, the most possible causes is poor adherence to prescribed medicines. Near 15% of patients has pseudo-resistant hypertension because poor adherence. White coat phenomenon. It's not so oftenly found reason of pseudo-resistance hypertension, but hence the recommendation to confirm office hypertension with ABPM or HBPM. Poor office blood pressure measurement, so it's bad technique, including the use of cuffs which are too small relative to the arm circumference, and it may be a result of pseudo-resistance hypertension. As a reason, it's marked brachial artery calcification, especially in older patient. Clinical inertia resulting of inadequate doses or irrational combinations or not enough doses. Other causes, it's lifestyle factors, especially huge obesity, especially excessive alcohol and high sodium intake. Intake of vasopressors or sodium retaining substance. Some herbal, some recreational drug use, cocaine, anabolic steroids. Obstructive sleep apnea often is a reason of secondary hypertension, undetected secondary form of hypertension. What important you must remember about secondary hypertension? It's typical for younger patients, less than 40 years, with second grade of hypertension or third grade of hypertension or onset of any grade of hypertension in childhood. Acute worsening hypertension in patients with previously normal or chronic stable normotension. Resistance hypertension. Severe grade 3 hypertension or hypertensive crisis. Presence of extensive hypertensive mediated organ damages. Clinical or biochemical features which suggest of endocrine causes of hypertension. Clinical features which suggest of obstructive sleep apnea. Symptoms suggestive of pheochromocytoma or family history of pheochromocytoma. If we talk about really cause of secondary hypertension, it may be obstructive sleep apnea. It's between 5 to 10% of all secondary hypertensive patients. This patient has snowing obesity, more in most cases, moaning, headache, and daytime somnolence. Screening investigation efforts go polysomnography for confirm renal parenchymal disease, mostly asymptomatic, diabetes, hematuria, proteinuria, nocturia, anemia, renal mass in adult polycystic chronic kidney disease. Plasma creatinine and electrolytes, estimated glomerular filtration rate, the most important. Urine dipstick for blood and protein, urinary albumin creatinine ratio, and renal ultrasound. Renal vascular disease is atherosclerotic renal vascular disease, mostly in older patients, widespread atherosclerosis, especially peripheral artery disease, diabetes, smoking, recurrent flash pulmonary edema. Or fibromuscular dysplasia, it's younger patient, more common in women, abdominal bruit. Atherosclerotic renal vascular disease, it's duplex renal artery Doppler or CT angiography or MRI angiography. For screening for confirmation. Other causes, coarctation of aorta, less than 1% of patients, usually detected in children or adolescents, different blood pressure, more than 20 to 10, between upper lower extremities and or between right left arm, and delayed radial femoral pulsation, low ankle brachial index, interscapular ejection murmur, rib notching on chest X-ray. Echocardiogram will confirm the diagnosis. Endocrine causes, it's primary aldosteronism, mostly asymptomatic, maybe muscle weakness, it's rare. plasma aldosterone and renin, and aldosterone-renin ratio, pheochromocytoma, episodic symptoms, the 5PS, paroxysmal hypertension, 5Ps, paroxysmal hypertension, pounding headache, perspiration, palpitations, and pallor. Labile blood pressure surges precipitated by drugs, plasma, or 24 urinary fractioned metanephrines of urinary or metanephrines of plasma during 24 hours from episode of pheochromocytoma, confirm pheochromocytoma, or exclude. Cushing's syndrome, moon phase, central obesity, skin atrophy, strand brushing, diabetes, it's steroid diabetes, chronic steroid use. 24 hours urinary free cortisol, confirm or exclude Cushing syndrome and Cushing disease. We also use dexamethasone test. Thyroid disease, hyper or hypothyroidism. Thyroidism, its signs and symptoms of hyper or hypothyroidism. Thyroid function test, it means free T4, T3, and TTH, the thyrotropic hormone. Hyperparathyroidism, it's a hypercalcemia and a hypophosphatemia. Parathyroid hormone and level of calcium must be measured. And the last slide, it's medication or substance which can provoke secondary hypertension. It's oral contraceptive pills, near 5% of women. Diet pills, for example, phenylpropranolone and sibutramine, I don't know what is it. Nasal decongestants, we talk about it for patients with different rhinitis. Stimulant drugs, amphetamine, cocaine, and ecstasy. Licorice, chronic excessive licorice use mimics hyperaldosteronism by stimulating the mineralocorticoid receptor and inhibiting cortisol metabolism. Immunosuppressive medication, for example, cyclosporin A, steroids, anti-angiogenic cancer therapies, bevacizumab, tyrosine kinase inhibitors, sunitinib, and sorafenib. Other drugs and substances, anabolic steroids, erythropoietin, which we use for treatment of chronic kidney disease with anemia, non-steroidal anti-inflammatory drugs, and herbal remedies, ephedra and mahuang. Thank you for presence, thank you for your attendance, and on the next week we will have next lecture. Before this lecture we'll have 30 minutes tasks with maybe tests or maybe other things. I don't know exactly, but on next week we will have, before lecture we will have 30 minutes answer on the question during your classes.